Then I will change the host.
A very good evening, namaste, and a warm welcome to the third SAARC Association of Anesthesiologists Continuous Professional Development Program. This is the third of the session of the SAARC AA webinars, and we have had two wonderful sessions before this. And today is no different. We have two very nice topics to be discussed by eminent faculty from the different parts of the SAARC nation. And to introduce the topics, may I request Professor Naveen Malhotra, sir, Secretary of the SAARC Association of Anesthesiologists, to please introduce the session for the day.
Thank you, Dr. Nishant, for the kind introduction. And I welcome all of you profusely to this session of SAARC AA CPDP. And I'm very pleased to have on board our esteemed colleagues from Pakistan and Maldives, who shall be sharing their pearls of wisdom with the colleagues across the countries of SAARC nations on very important topics, securing airway in pan-facial trauma, as well as a very clinical and relevant topic of post-dural puncture headache. It's my pleasure to extend warm greetings to the office bearers of the Pakistan Society of Anesthesiologists Karachi branch, Maldives Association of Anesthesiologists, Bangladesh Society of Anesthesiology, Critical Care and Pain Physicians, College of Anesthesiologists of Sri Lanka, SAN, Society of Anesthesiologists Nepal, ASA, Afghanistan Society of Anesthesiologists, and office bearers of Indian Society of Anesthesiologists, our parent body. And I extend warm welcomes to Dr. M.B. Bhimeshwar, the chairman of ISA Academic Committee, Dr. Virender Sharma, treasurer of SAARC AA, and executive member from India, Dr. Anjali Bhure, past vice president of ISA National. And I'm thankful to the coordinators of today's program, Dr. Nishant Sahay and Dr. Neha Sinha. Last but not the least, warm regards to Dr. Venkat Giri, President SAARC AA, Dr. J.V. Divetia, President ISA National, and dear Dr. Sukhminderjit Singh Bajwa, Secretary ISA National. I request Dr. Nishant Sai to take forward today's scientific program, and I wish good luck to all the delegates that they will have a good scientific and academic interaction with the esteemed speakers from Pakistan and Maldives. Thank you, Dr. Nishant.
Yes, sir. We are all excited regarding the talk for today. Very interesting topics. May I now request Dr. Venkat Giri, sir, President of the SAARC Association of Anesthesiologists, for his few words.
Good evening. Thank you, Nishant and Naveen. Good evening, all presidents and secretaries and office bearers of SAARC countries, SAARC office bearers, and today's faculty and chairpersons. Now we are back in track. We are with the meeting regularly, and a good thing that this month we are having two meetings, and so hopefully that next meeting also will be very soon, and they are already ready with the topics of Maldives and Bhutan. So we will have that meeting soon. So we hope good academic activities in the coming days, and also soon our journal will be published. Thank you.
Thank you, sir. And may I now hand over the stage to my colleague, Dr. Neha Sinha, a very promising pain specialist from Rohtak. Dr. Neha, please.
Thank you, sir. I welcome all delegates and our esteemed faculty members and chairpersons for this evening. So without any delay, I would like to start with the first session, that is challenges in airway management in a trauma patient. And for this, I would like to invite a very eminent chairpersons for today. Our first chairperson of the evening is Dr. Professor Saida Haidar, ma'am. So can we have the slides, please?
Yeah.
Welcome, ma'am.
Thank you.
Thank you. Thank you very much, Nishad. Do you have to say something?
Yes, ma'am, of course. Ma'am is the
Well,
chairperson and
it's really,
HOD in the
I mean,
department.
I've been associated with SAARC since the beginning when it was known as SAARC, actually, initially, when it started in 1991. So I've been associated with it, and it means a lot to me. And it's really, I feel great to be a part of this meeting today. And hopefully we'll see each other in December. December, I believe, we are having the Congress. And I
Yes,
look
Yes, ma'am.
forward to a wonderful
yes, madam.
session. Both Farjad and our Rizana, who will be speaking um, from Maldives. And thank you very much. Thank you. Let's go ahead.
Yes, ma'am. So, ma'am she's currently chairperson and HOD in the Department of Anesthesiology and Critical Care at Indus Hospital and Health Network in Karachi, Pakistan. She is a professor emeritus. She is the patron of Pakistan Society of Anesthesiologists, Karachi branch. She's been the former chairperson in the Department of Anesthesiology in Dow University of Health Sciences, Dean Faculty of Anesthesiology at College of Physicians and Surgeons of Pakistan. Has been and is still a passionate teacher and trainer of her field. So, ma'am, now
Thank you.
coming on to next chairperson for this session. It's none other than our Dr. Naveen Malhotra. Sir is director at APMC, AS Pain Management Center, Rohtak, Haryana, India. He has been the former senior professor and head at Pain Management Center, PGIMS Rohtak. Sir has been awarded the Gopal Award for Academic Excellence in 2015. Also the KPR Young Anesthesiologist National Award in 2009. Sir is currently the president of the National Society Research Society of Anesthesiology Clinical Pharmacology. Sir has been the chief advisor for the 2023 revolutionary secretary of the ISA National and has been very fondly known as our own national secretary for the tenure of 2018 to 22, honorary secretary of the SAARC from 22 to 24, also the deputy chair of the Asian Australasian Regional Section for WFSA, member intensive and critical care medicine and the committee of the WFSA. So we welcome you, sir.
Thank you, Dr. Neha. Thank you very much.
Moving on, I would like to introduce our speaker of today's session, Dr. S. Farjad Sultan, sir. Sir is the chairperson of anesthesia at Dow University of Health Sciences. He is the director of the Professional Development Center at the university and has been responsible for managing of the undergraduate skill lab, AHA activity monitoring of Pakistan, that is the Asif Rahman Simulation Center and the CME section at the DUHS. Sir is an FRCA from England and has been awarded with the CCST and is on the specialist register. He has a fellowship in critical care from the College of Anaesthetists Ireland and a PhD in training in and assessment of procedural skills required for ultrasound guided peripheral nerve blockade from the National University Ireland, University College Cork, was awarded in 2016. He has been the former head of critical care in this hospital, Karachi. He has been instrumental in implementation of COVID ICU at Civil Hospital, Karachi, and has been responsible for planning and running of the standalone COVID ICU at the Expo Center, which was running for 2 years. And he's been as a volunteer and has been treating nearly 4,000 organ failure COVID patients with his team. He has represented just at multiple international conferences as a speaker and as a keynote in national conferences, master trainer for ICU and trauma courses, as well as a trainer in all anesthesia and ICU related national conferences in Pakistan. It's a pleasure having you, sir. I hand over the stage to you for your talk, sir. Welcome, sir.
Thank you very much. I'll just start my presentation over here. There we go. So first of all, I would like to thank the organizers for giving me this chance to speak at the SAARC AA. And it is truly an honor having attended most of, if not all, the SAARC conferences that I've been able to over the years. So the topic I have, I'm going to present is challenges to airway management in trauma patients, the concept to bedside. So the components of the respiratory system are quite extensive there. We do divide them into the upper respiratory and the lower respiratory system. And each of them are quite delicate, and a lot of things can happen to these things in a trauma situation. And as you know that the lungs are protected by the rib cage, but the upper airway is not. There we go. So yes, so what are the problems that can happen in a polytrauma patient? Well, it depends on the site of trauma. If you can see the picture, it can be anything. So the injury to the patient's face, neck, airway in the event of crash, there may be anatomical obstruction, and that needs identification. And whenever such things happen, it's always an unfavorable environment. It's a roadside. We're working in an ambulance. There's low lighting in the evening time. At night time, there's limited space and mobility. And generally speaking, there's never a single patient, there are multiple patients. And then there's the concept of and the problem of team coordination. Coordination between the healthcare teams, whether they have the appropriate expertise, the appropriate equipment. Everything comes down to having the communication. So the most common thing that we have been taught is the ABC approach: open the airway, breathing, and circulation. But the AHA guidelines have gone to CAB. So if we need to go to circulation first, that's fine in case of a cardiac arrest. If not, we do go to ABC. Then we go through the assessment part. We do a quick history and examination, primary survey, secondary survey, and then is the decision to intubate. And once we have decided to intubate, we need to plan to intubate and keep in mind all these challenges of the unfavorable environment that we have. So it's not an easy decision to make to intubate at the trauma site, but if needed, that is what it needed. Then we need to plan the intubation. Until that stage, we need to maintain oxygenation and ventilation via a definitive airway. So the most well-known and time-tested is the rapid sequence induction. One has to be aware of the hypovolemia. So a trauma patient we expect hypovolemia in all of them, and all anesthetic medication, with the exception of ketamine, are myocardial depressant and vasodilators. So you do run into that problem. The strategy is to secure the airway safely. The keyword is safely, preferably a definitive airway. And if not, there's always a plan B, the advanced airway device. What are the benefits of the RSI? It's fast onset, it's time-tested and proven, and it reduces the risk of aspiration and related complications. What is the role of advanced airway? Well, the surgical airway is an extreme measure when all health has failed or there is no other option. And again, the expertise need to be there. Everyone cannot do a surgical airway. Everyone should not be allowed to do a surgical airway. It is an extreme measure. The other airway devices and adjuncts that we have are the supraglottic airway devices, modified laryngoscopes, the video laryngoscopes, and the use of ultrasound. In the supraglottic devices, we do have quite a collection in our armament. We start with the classic LMA, the ProSeal LMA, which has the external gastric tube. We have the intubating LMA and the iGel, which has made life quite a bit easier compared to the classical LMA. And then the modification to the conventional laryngoscope, the Miller. Again, I would want to stress on the fact that if you've never used a Miller before, don't use it in a trauma patient. You want to use these equipments, use them on an elective list in a controlled situation so that you know how to use it. Each equipment has its own technique of using it and pros and cons. Then we have the Macintosh with the movable hinge. It is quite handy if you know how to use it and if you have practiced on it and if you have a skill on it. Otherwise, it can be quite a hassle and it can cause more harm than good. Then we have the video laryngoscopes. We have the channel devices and the non-channel devices. And there is a vast range of these available in the market. Some of the most common ones that we have are the AirTrack, the Pentax video system, and the Rescue Scope for the channel devices. And for the non-channel, the Glidoscope, the CMAC, and the McGraw. Again, I want to stress on the fact that please use them in an elective control setting before trying them out in an emergency setup. And it does have a skill set and there is a learning curve to it. And then we have our old trusted friend, the flexible bronchoscope or intubating laryngoscope. And again, there is quite a steep learning curve to it, and we do need to learn how to do it before putting it into a patient. Then there's a role of ultrasound in airway management. Ultrasound is quite handy It is portable. We can visualize anatomical structures in the supraglottic, glottic, and subglottic regions. Epiglottis may be a challenge because it is suspended in air. The vocal cords can be visualized and movements can be appreciated by the use of ultrasound. If you choose to do a cricothyroidotomy, it can identify the cricothyroid membrane and if there is damage to it or not. And it has only been used to predict difficult airway in a small series of obese patients. Regarding tracheal intubation, ultrasound can reliably confirm the correct placement of endotracheal tube. So if it is a difficult intubation and you have sighted a tube blindly and you don't know, you can put on the ultrasound probe and you can see the tube in the larynx or not. It is quite handy for percutaneous dilatation or tracheostomy, and I have a habit of using it regularly for the PDTs. It does identify the anatomy, it does identify vessels and all the percutaneous structures, and it saves such a lot of time and hassle with the potential complications. But what is the problem with trauma and airway management in the trauma? Well, first is the training. Where do we train the patient? Where do we train our colleagues and our juniors in it? And usually trauma, there's no time for trauma. It's unpredictable. And all trauma patients do not require an emergency airway. And if they do come, will one of us be around to supervise it? Maybe we're stuck with some other patient, a trauma patient comes in. So one of the things is that we have to remember the context of it. We have to remember our Hippocratic oath, the primum non nocere, first do no harm. To err is human. In 1990s, this was reported on patient events. The traditional practice has been see one, do one, and teach one. But now there is a paradigm shift of observe some, practice several, and then perform. And the team approach to patient care. One person cannot do everything. One person cannot care for a patient alone. It has to be a team approach to patient care. So part of the solution is simulation. Simulation is the act of mimicking a real object, event, or process. So is simulation a valuable tool? Well, if you think about it, learners can learn without risk to patients. Learning can be focused without any regard to patient care need at that time and place because it is a simulation. And there is opportunity to repeat a skill or lesson up to mastery if required. And for individual learners, we can have specific learning opportunities which are guaranteed. So if you want to have an anterior larynx, you can have an anterior larynx. If you want to have a difficult airway or a PDT, you can practice on it. And learning can be done at a convenient time in a place where it is perfectly safe, there is no patient involved, and the performance can be recorded and then replayed again for feedback or debriefing afterwards. It is a team building activity. It focuses a lot on the communication skills that are required. New technologies can be safely taught. So all our video laryngoscopes, all our fiber optic bronchoscopes, all our equipment that we need to teach our residents can be done. Professional competency can be assessed wherever it is required for credentialing and recredentialing, and it is deliberate practice. We practice more and more and more, and we will get better. But we have to remember, simulation is just one tool. It is part of the solution. It may not be the solution. So you have to remember it is there to be used if planned appropriately. So where's the evidence for it? Well, we have lots of evidence. Trauma assessment training with the patient simulator prospect randomized trial in the Journal of Trauma. It demonstrates advantages of simulation to other modalities of training. Again, when we're talking specific things, team working as a team, taking individual skill sets and then combining them all together to make a whole teamwork, sort of making a jigsaw puzzle into a complete picture. In another study in the teaching and learning in medicine, residents who participated in simulation outperformed their counterparts in a mannequin-based anesthesia simulator. Leadership and teamwork in trauma and resuscitation from the Western Journal of Emergency Medicine. This review article gives a very nice review of how things are, how things can be, and the potential of where things can progress too. Simulation improve teamwork and team performance. This is quality, safety, and healthcare. So it does work. So why don't we do it? Well, that is quite a interesting question. And with that question, more questions arise. Where to do it and who will do it? So what does it actually take? Well, it takes scenario building. It takes a lot of time and energy and training to do it. The simulation training of the faculty and staff, the scenario building training, the appropriateness of learning objectives or outcome, and with each simulator or simulation center, there is quite a significant cost attached to it. And it is a part of continuous development process, and it should be a part of continuous development process, and we should be doing it. So in conclusion, trauma patient management is all about teamwork. The airway can be a challenge in the trauma patient. Training via simulation can be utilized to build expertise. Simulation is just one tool in the teaching and learning cycle. There are other things available. The more we do, the more we teach, the more we learn as well. Simulation has shown increased skill retention, higher confidence, and improved patient outcome. Simulation is an effective and efficient way to train personnel and bring concept to bedside. Thank you very much. Short and sweet presentation.
Thank you, sir, for the short and very comprehensive idea about airway in trauma patients. I would now like to invite our chairpersons for this session to take over and start with the discussion. Dr. Saida ma'am, Dr. Naveen sir, over to you.
Thank you, Dr. Fardat Khan, for an excellent and brief talk on airway management in a trauma patient. I just want to like to add on about the role of subendotracheal intubation and retromural intubation in avoiding perioperative tracheostomy in patients with panfacial trauma. And I'll share my views over that, but I like to listen from you first.
So we don't do a lot of these. In our trauma, what we do is we have a trauma center separately. So all the facial trauma usually goes to the trauma center. And if there is a lot of facial trauma, our surgeons are quite handy. And generally speaking, the trauma that we get is quite extensive, and we expect long-term intubation. So as a protocol, if it is that bad and there's head trauma involved, and we are expecting prolonged intubation, we just go for a surgical trachea. The training required for retromolar is, again, it is a skill set. It needs training. And again, it is something that can be trained in patients, in simulated patients. But there is an equipment issue as well in government sector. We do have one retromolar intubation set, but there is a steep learning curve to it. I don't personally do it. We have an algorithm of approach to the trauma patient. But again, if there's a head injury involved as well, we stabilize the patient, maintain airway, and just go for a tracheostomy as early as possible.
Thank you for your inputs. I personally have a long and extended experience of avoiding perioperative tracheostomy in patients of trauma, especially the panfacial trauma. I agree with you that the tube which is submetal can be placed for around 72 hours. So definitely those patients who are going to require a long-term ventilatory support are not the candidates for subendotracheal intubation. Retromolar intubation is of two types. One is Bonfils retromolar scope-guided intubation, for which you require a specific equipment. But the main indication for that is patients with the limited mouth opening coming with TM joint ankylosis and restricted mouth opening, burns, and so on and so forth. The other one is a simple manual repositioning the metallic tube to the retromolar space, which is the space behind the last erupted teeth, whether they are the premolars or the molar. You do a normal conventional laryngoscopy with a flexometallic tube and then manually reposition it into the retromolar space, which is the space behind the last erupted teeth, the upper and lower one, and then fix it with a dental wire to any of the tooth, so that you can do the intermaxillary fixation, which is a very important step for patients with panfacial trauma, because the restoration of the dental occlusion is one of the cornerstone step for the surgical procedures. If the space behind the last erupted tooth is not adequate, then the retromolar intubation is not successful. But there are certain tips and tricks also. You can select a smaller size tube. It's if you put a 7.5 mm in a male patient, which has a corresponding lesser outer diameter, then that will be taking the space behind the retromolar region, and it can fit in there. Also, you can do just simply by putting your own finger, gloved finger, into the patient's mouth and asking him to clench it. And if there is no pressure on your own finger, everybody knows the outer diameter of their index finger. So, okay, this is the outer diameter, and then this much type of tube will be easily fitting in the retromolar region. If for any chance you are not able to do the retromolar intubation, then submentotracheal intubation or the submental intubation is the minimally invasive technique of avoiding perioperative tracheostomy in patients with panfacial trauma, where you do a blunt dissection just lateral to the mentum, and 1 to 1.5 centimeter incision, and you do a blunt dissection through skin, subcutaneous tissue, and the myloid muscle, and open into the floor of mouth. Again, the conventionally direct laryngoscopy introduced flexometallic tube whose connector can be removed is now repositioned from orotracheal route to the submentotracheal route. It is pulled out. First, you pull out the pilot balloon, and then you take out the endotracheal tube. In both the techniques, whether it is the retromolar intubation or the submentotracheal intubation, the exit point is around 2 centimeters more than the oral exit point. If it is, suppose, 18 centimeter at angle of mouth, in the retromolar intubation also it will be 2 centimeters more, because the tube is going to take a curve. And in the retromolar also it is going to take a tube. In the submento also it is going to take a slightly longer distance, so that will be more than 2 centimeters. And then you switch it with 1020 scale suture. And then also intraoperatively you can do a maxillomandibular fixation in these patients of panfacial trauma. At the end of the procedures, because these patients normally we would have been done a nasotracheal intubation, but patients with Lee-Ford-3 fractures, CSF, rhinorrhea, epistaxis, or fracture of nasal bone or nasal orbital ethmoid complex, you do the surgical procedures in the nasal septum also, in the nasal bones also. So there will be a nasal packing. So that's why nasal intubation could not be done, and we had to restore to either retromolar intubation or submentotracheal intubation to avoid perioperative tracheostomy. So nasal packing is there. So surgeons would definitely remove that elastic bands for few hours after the surgery, so that everybody is sure of the hemostasis also. And you do a thorough orotracheal suctioning. In retromolar intubation, you convert from retromolar to orotracheal and then do a standard extubation for any endotracheal tube. And in the submentotracheal intubation, you can simply pull out the tube also after deflating the tube and then applying 2-0 interrupted skin sutures and the wound to heal by secondary healing. So these two techniques are handy, and they are the armamentarium of anesthesiologists only, and they have got a selected role in patients with panfacial trauma, where we want to avoid a perioperative tracheostomy to secure the airway. So these are my inputs about retromolar and submentotracheal intubation. I request my esteemed chairperson, Madam Haider, to please express herself.
Thank you, Dr. Malhotra. What I understand from your talk is that both of them are wonderful techniques, and what I feel is that we are talking about trauma and difficult airway. I mean, where you are talking about retromolar or submental, you're talking about more about difficult airway rather than facial trauma, because the facial traumas that I have seen, I would rather concentrate on the fact that, please, for heaven's sake, quickly clear the airway. And the maintenance of airway is very important before we reach a definitive, like the simple measures. I think we should not miss out on those, because a lot of juniors must be here listening to these talks. And I feel that they should not forget this step, because we must remember that deaths by trauma happen, there are three peaks of death. One is, of course, immediately those patients that you can't do anything about. But the second one is the one that where we come into, and where we can really save lives. Not give a hypoxic person to the family. And this second peak where we can deal with is actually going to decide how the patient fares later on. Like, he doesn't die of sepsis or MORS, because what have we done? Once he reaches the hospital. So if he reaches the hospital, he is very popular over here. And the AD used to bring patients.
Nishant, is Madam audible?
No,
I
I
think
think there's some
think
internet
she
issue.
has.
Must be
Right.
something with the internet.
Yeah, some internet. Madam is absolutely right that our first aim should be to secure the airway. And Dr. Fazad has very rightly highlighted that for that, simulation is one of the key thing, but not the only thing. And but at the end of the day, in addition to everything, airway management in panfacial trauma is the cornerstone and is equally important and no less than other measures. I invite other delegates, if they got any comments or queries. We are well in time, so we can take 2 or 3 more comments or queries from the esteemed delegates by the time Madam logs in again.
So I'm just going to make another comment that simulation is great if you want to train people for teamwork. But the problem with simulation centers is that there's a huge cost implication attached to developing one. So I think, and again, for all academic activities, if we have collaboration between institutes, we can achieve more. And in the end, everybody is trained as a team. And so what usually happens, and which has happened over the past, that only a certain set of doctors are trained in a certain specialty or a trauma course. But if we don't involve the paramedics as well, that changes things. Once we involve the paramedic, that changes things. And it just improves work in the ER and all these places amazingly. And in the end, it is all about improving patient care and ensuring that the patients get good care, quality care, and have a great life afterward for whatever disease process that they have.
Right.
Exactly, that's a good
More
thing
things and
to know.
discussions.
Because I think platform where we can think of collaborating also at the level of SAARC. Vimeshwar is also there, who is leading the academic committees. Other officers of different associations are there. That definitely simulation is an important tool, and we can start something maybe on a virtual mode onto the contact frames, so that our delegates across the different countries benefited by the simulation and its advantages.
I think there's a question over here
One or two
by Professor Banik. Which one is more effective to maintain airway with face trauma and burns between intubation and tracheostomy? Well, if it is a facial burns and trauma, and we are expecting the patient to require ventilatory support for a long while. Again, there is no, without looking at the patient or assessing the situation, there is no absolute correct answer that intubation is better than tracheostomy or vice versa. But there's a huge variability. If I have a patient who I know has extensive facial trauma and has a lot of soot, and I know will be ventilated for a long while and will require multiple surgeries, I think even though our surgeons are going to prefer a tracheostomy, it just makes life easier for the surgeons and all the people combined. But if it is something which is transient and may require 70 to 48 hours of intubation, then we would go for 70 to 72 hours of ventilatory support. Then I would offer an intubation. But again, there's a huge variability between patient to patient. I cannot for sure say intubation is better than tracheostomy or tracheostomy is better than intubation. Any other comments?
Yeah, I agree with you. There are definitely two schools. One go for early tracheostomy and one go for late tracheostomy, with benefits and demerits of both the techniques. And you have to select the patient individually. And after clinical examination only, you can see whether this patient will be extubated in 3 to 4 days or may require a long-term ventilation. We got Madam Heather back again. Madam, your comments, please.
Yes. I think let's have comments from the audience. I mean, if anybody has any questions, we should promote audience participation. That would be good. My comments were that we should not forget the simple things that we can do, and every trauma patient does not have to be a difficult airway. We should also, when we're talking about challenges in a trauma patient, we should talk of a normal airway as well, and that will be having a lot of challenges. I myself have had, sort of a bullet going through and through, and half the mandible going away. But I could still, sort of do a laryngoscopy, and with the suction on, I could intubate the patient. So these are little things that we must not forget before actually, I think, going on to more complicated solutions. We can have simple solutions to very, very major problems, actually. Any audience has any question
or comments?
Or comments?
Yes, the audience is encouraged to type their questions or comments in the chat box. They can unmute themselves also if they so wish.
Yeah.
Got time for 1 or 2 minutes.
So there is
Fazal?
the question.
Yeah,
Yes, about nasal intubation versus tracheostomy in case of mandibular fracture. I think Naveen sir explained quite a lot of detail about the pros and cons of mandibular fracture and to avoiding a tracheostomy. If I can avoid a tracheostomy, I will. But again, in a complicated facial trauma where there's CSF rhinorrhea, where nasal intubation is not possible, Raveen sir was very rightly has described the retromolar and the submandibular intubation techniques. So my personal view, if I can avoid a tracheostomy, I will. If the nasal intubation is possible, I will go for it for mandibular trauma. But better safe than sorry. If I don't have any access for it, then we'll have if we can't and there is no option, then we would do a tracheostomy. Then I would offer a tracheostomy if I don't have any other option. But I would avoid one if I can.
I too agree. Bottom line is to avoid perioperative tracheostomy and its associated complications if you're able to secure the airway by any other conventional route.
Sometimes, Doctor. Sorry.
Hello. Can I say something? I'm Rizana from the Maldives. I would like to agree with Professor Haider. I think if there are trainees here, it is very important for us to remember the main thing is oxygenation of the patient while we are thinking of how to secure the airway. I think that should not be forgotten. throughout the procedure, that the main thing is to maintain oxygenation for the patient while we think of how to best secure the airway.
Yeah, taking that forward,
true.
ma'am. Yeah, like, sir, Dr. Fazad, one of the problems that sometimes we face is in a trauma patient, there might be, as ma'am said, oxygenation is very important. There are uncooperative patients for which we need to pre-oxygenate. So we'll have to go again for, we are taught that we must go in for RSI. How can we modify that a little bit for pre-oxygenation in an uncooperative patient where oxygenation is very important?
So in an uncooperative trauma patient, there has to be a reason why they're uncooperative. Either they have pain or they have a head injury. There has to be a reason. So if it's pain, I would give them some analgesia. Small dose of an opioid will help. But if it is a head injury and they're agitated because of raised ICP, then that changes things completely. So we need to identify first in a survey of what is causing the problem. Once you've found the problem, we sort the problem out and things are going to become easier. So again, patient assessment is the primary. So if a patient is uncooperative because they have a number of fractured ribs or a fractured leg, or they're agitated because they're hypoxic, because they have a pneumothorax, or they may be developing a tension pneumothorax, then we need to sort that out in the primary survey first beforehand. But oxygenation is important. There is a question about cracothyrotomy in an emergency. Again, cracothyrotomy needs quite a bit of training. Everybody cannot do it, should not do it. It is there. And the thing that what I would do in a cracothyrotomy situation is, if I cannot get any oxygen in, I would do a cracothyrotomy to give the oxygen in to save someone's life, and then get stuff ready for some way to secure the airway. But I would not routinely do a cracothyrotomy. I would prefer tracheostomy over a cracothyrotomy in any case, in any way, but one needs to be trained in it. If you're trained in it, then you have a wide armament to choose from, and training will only happen if you have exposure to it as well.
Yeah,
Yes,
most
sir.
of the time it so happens that, and Dr. Fazad is right, that front of the neck access, we're doing it in an emergency situation where the saturation is rapidly deteriorating, with heart rate also sinking down, bradycardia occurring, and you're going for a technique which you have not practiced in the last many years. So here comes
Yeah.
the role of simulation also, and the workshops also. And as a life-saving measure, we need not be, we should be practicing either in the simulation or in the workshops or in the animal models, the cricothyrotomy. There are certain questions about the flexometallic tube in retromolar and subendotracheal intubation. I must say that gone are the days. Initially, we had a very difficulty when there were silicone tubes whose tracheal tube connectors could not be removed. But now with the PVC tubes, the connector is fixed with a glue. You just put it in a lukewarm water, and with a curved artery forceps, rotate it around, and these connectors can be easily removed. So once you're planning to convert it from oral to subendotracheal intubation, you can remove this connector and take out the tube. And having a flexometallic tube in the retromolar region is very, very useful. There is no problem in it, rather it is very beneficial because it will adjust to the curves and there will be no kinking and increase in airway pressures. That's comments on those two questions. Dr. Acharya from UK is Dr. Shambhu Acharya. Welcome, sir. Sir is mentioning that please do not forget that there is a gap, that is the missing tooth. Small tin can be placed, and that is definitely, sir. Many times we have seen that 2 to 3 teeth are missing because of the trauma, and that can be used to place the tube, and that serves as a space where you can reposition the tube rather than putting it at the angle of the mouth, but using it at the space provided by the missing tooth. So I think we are on time, and me and Madam Heather congratulate Dr. Fazad Sultan for a nice topic on airway trauma, management of airway in a trauma patient, and encouraging such a nice discussion. And I thank the organizers for.
Thank you, Fazad. Thank you, Dr.
You're
Malhotra.
welcome, ma'am. Thank you, sir.
Thank you, sir.
Thank you,
And
Neha.
yeah.
Thank you, sir. Thank you, ma'am. It was a wonderful discussion, and I hope we all are benefited with this crisp discussion. So I would now like to hand over the stage to Dr. Nishant Sahai for taking this SAARC CPDP forward and moving on to the next session. Over to you, sir.
Yes, thank you, Dr. Neha. And that is the beauty of this forum. We had an engaging discussion with the experts from all over the SAARC countries. Coming to the next part, we have another very interesting topic. And for this, may I request Dr. Rizana Abdul Ghafoor. Madam, she is the Associate Specialist in Anesthetics, Medway Maritime Hospital Foundation, NHS Trust. She's a former consultant and head of department of the Department of Anesthesiology at the Indira Gandhi Memorial Hospital at Malé in Maldives. She's one of the founder members of the Maldives Anesthesiologists Association. A very warm welcome, madam.
Thank you very much. It's a privilege to be invited here.
Welcome, Rejwana Abdul Kadir from
Thank
Bangladesh.
you. I can see that I have met few of the esteemed members here. I can recognize some.
Thank you, ma'am, and we look forward to an engaging discussion. Next, we have Dr. Major M.V. Bhimeshwar, sir. Sir is the principal at Dr. Pinnamaneni Siddharth Institute of Medical Sciences and Research Foundation at Vijayawada in Andhra Pradesh. Sir has been the president of the Indian Society of Anesthesiologists in 2023, a board member of the Asian Australasian Regional Section of the WFSA between 2018 to 22. Sir was the vice president of the Indian Society of Study of Pain in 2015, additional director of medical education for the government of Andhra Pradesh from 2022 and 2023. Sir is the controller of examinations of the Dr. NTR University of Health Sciences at Vijayawada and a registrar at the NTR University of Health Sciences in 2019. A very warm welcome, sir. A few words.
Thank you. Thank you, Nishant. It's really a pleasure to be here with all of you for this wonderful session on SAARC CPD. And I really thank Dr. Naveen, Dr. Venkatagiri for such a wonderful initiative, and all the office bearers like Dr. Anjali Bure, Dr. Virendra Sharma and all for a wonderful initiative, and I have been part of it once. And the topics chosen were also really good for these two sessions. And as we go with the second topic, I'll again reserve my comments for the last regarding the topic and all. Thank you very much.
Thank you, sir. And to deliver this talk, Dr. Dusuma Abdul Razzaq. She's the consultant and head of Department of Anesthesia at the ADK Hospital in Maldives. She's the current president of the Maldives Anesthesiologists Association. A very warm welcome, ma'am, and we are all eagerly waiting to listen to your talk on post-dural puncture headache management. Over to you.
Thank you. Sure.
Ma'am, you'll have to share the screen, please.
Sir, give me a...
Yeah, no problem, ma'am. You can just, I think ma'am is trying to set up her PowerPoint. You need to share screen, which is the red, the green arrow at the bottom, 6 p.m. So we have a lot of dignitaries from all over the SAARC nations.
So I'll request in the meantime, Dr. Kavatsar Sardar or Dr. Manik sir to invite the delegates to the forthcoming
So I have to
SAARC
leave and
conference.
rejoin. So I will leave for right now.
You want to rejoin, ma'am?
I have to leave and rejoin. So.
Dr. Kavatsar Sardar, we can use this opportunity to invite the delegates and the colleagues of the SAARC country to the forthcoming SAARC AA conference, which is going to be held in Dhaka, Bangladesh, along with the Golden Jubilee Conference of Bangladesh Society for Study of Pain, Critical Care and Pain Physicians. And I take this opportunity to invite all of you to register in big numbers and be there with us in Dhaka, Bangladesh on 6th, 7th and 8th December 2024. And as Dr. Giri has said, that soon we will be having, Dr. Manik is there, sir. Dr. Manik, sir, please unmute yourself. Professor Manik, sir.
So please enable.
Yes, sir. I am this evening. I am very much pleasure to attend this CPD program, especially Professor Tipu Sultan. He is my direct examiner of my fellowship examination in Dhaka, and also Saidar. There as a founder member of the SAARC, and I invited, and this is the fourth time in Bangladesh to arrange the SAARC conference in upcoming December 8th to 10th. And all are invited to attend this Congress.
Thank you, sir. Thank you for the invitation. I think Dr. Dusoma madam is ready with her presentation, ma'am. Your slides are visible. Can you please continue?
Thank you. Good evening, everyone. I would like to thank you all for giving me this honor to present in SAARC. Today, my topic will be like evidence-based approach to diagnosis and management of post-dural puncture head.
Very good, very good.
Most of my presentation is based on this consensus practice guideline on post-dural puncture headache. This from a international working group by Vishal et al. And also some of the information is from the statement by this American Society of Anesthesiologists, which was released in October 2021. And thus strength and certainty of evidence is recommended based on this grading. So I thought I would like to you all familiarize with the grading, how it is. That's why most of the slides I'll be using about this grading. And if it is a evidence grade A, that means that US Preventive Service Task Force that recommend the services, and it has a very high certainty that the benefit is substantial for that. So we must offer or provide that service. And grade B2 that has a moderate net benefit, and we should offer and provide that service. And grade C, it has the offering of that service should be individualized based on the individual circumstances. And if it is grade D evidence, then you must discourage the use of that service. There is substantial evidence against the benefit. And if grade I, that means it concludes that the current evidence is insufficient to assess the benefit. So if we are using that service or if we are offering, we must see the balance of benefit and harm, and then only should consider. In post-dural puncture headache, that is recognized complication of dural puncture. And this dural puncture may be unintentional for labor epidural analgesia example, or it may be unintentional. It may be for like certain surgeries and also for after lumbar puncture. Its incidence varies, ranges from less than 40%. It varies due to certain factors because most of it depends on the patient factors and also procedural factors. Post-dural puncture headache, previously it is known as post-lumbar puncture headache. It is International Headache Society has described in 2018, this headache is occurring within 5 days of lumbar puncture, and it is attributed to cerebrospinal fluid, low cerebrospinal fluid pressure due to CSF leakage, and through the it is accompanied by neck stiffness or subjective hearing symptoms, which may be resolved within 2 weeks. And in this definition, like okay, in this IHS classification, which has a lot of limitations, like here it says that CSF headache which occurs within 5 days of lumbar puncture. Even sometimes post-dural puncture headache can occur even after 5 days of lumbar puncture. And if to diagnose post-dural puncture headache according to this definition, that CSF leakage has to be documented. There should be an objective measure for that. So it is very difficult based on the clinical symptoms to diagnose. And sometimes the headache might not resolve within 2 weeks. So we need another measure or another way of identifying or diagnosing PDPH. And to make the diagnosis more clinical, American Society of Anesthesiologists, in their statement in 2021, they have included these typical symptoms, like which include neck stiffness and pain in cervical, thoracic, or lumbar area, and presence of subjective hearing symptoms, visual disturbance, and vertigo. And some important questions for diagnosing: when should PDPH be suspected? In this question, PDPH should be suspected if the headache or neurological manifestations may occurs within 5 days, and also they have included this postural component. That means pain is relieved in lying flat or reduced, which has a moderate level of certainty. And then the recommendation was follows. They have recommended in patients who have received a neuroaxial procedure, they should be reviewed and evaluated for symptoms of PDPH. If the patient is like outpatient patient, then the physicians, they should be educated to look for PDPH symptoms. They have given evidence grade A and the level of certainty is high. So based on those information for definition of PDPH, if there is a postural headache, like presence of postural headache, then usually fronto-occipital, and if it is associated with neck stiffness, photophobia, nausea, and tinnitus, and its onset within 48 hours, and it is resolved within 2 weeks, and earlier, if epidural blood patch is used, we can diagnose it as a post-dural puncture headache. And since this headache is depending on patient and factors and also some procedural factors, we can see that in this consensus statement, age, that means in this adult population, the younger the age, they have a higher level of certainty to develop PDPH. And also in the female sex is associated with a higher increased risk of PDPH. And BMI, if it is a higher BMI, there is a moderate level of certainty of developing PDPH. And then the headache, we can see that presence of migraine or history of migraine there is not having enough evidence to support that the PDPH is higher. But presence of chronic headache, there is a moderate level of certainty that there is a high risk of developing PDPH. And now, I'm sorry, this slide's a bit. And now comes to the procedural characteristics associated with dural headache. You can see there is a high level of certainty in needle type, means the cutting needle has a higher association with risk of PDPH, and needle size, it means the lower the gauge we use, there is lower risk of developing PDPH. Only those two has a higher level of certainty for developing PDPH. Other factors like number of attempts and operator experience, level of neuroexorbitable patient positioning, they have a moderate level of certainty in developing PDPH. The operator experience here, the more the experience, then there is less chances of developing PDPH because less chances of dural puncture. And what measures may be used to prevent PDPH? They have recommended placement of an intrathecal catheter that reduces the risk of developing PDPH. Its level of evidence is grade C and level of certainty is low. And the second thing they have advised is prophylactic epidural blood pitch via an existing epidural catheter or a standalone procedure. However, evidence is grade I and level of certainty is low. And prophylactic bed rest, which was inconclusive, and it has like evidence grade D, level of certainty is moderate. Prophylactic bed rest, however, gives a temporary relief to the pain. And what conservative measures may be used to treat PDPH? There are like bed rest has recommended, but since it gives a temporizing measure for symptomatic relief, and it may not cure PDPH. Evidence grade C, level of certainty is low. And the hydration, the best option is to maintain normal hydration, and hyperhydration is often harmful. So the fluid, intravenous fluid, should be used only when oral hydration cannot be maintained. Evidence grade C and level of certainty is low. Use of regular multimodal analgesia, that is acetaminophen and non-steroidal anti-inflammatory drugs, we must offer to all patients unless it is contraindicated, and it has evidence grade B and level of certainty low. And use of caffeine, we must offer in the first 24 hours of the symptoms with a maximum dose of 900 milligram per day. If it's breastfeeding, then it should be less than 200 to 300 milligram per day. Caffeine also, we must offer orally, and if it is able to take orally, then only, not able to take, then only we should consider intravenous route. It has evidence grade B, level of certainty low. However, use of short-term opioids, and it is not recommended unless while patient is on multimodal routine analgesia. And then if it is not helpful or some breakthrough pain is there, then only we can consider short-term use of opioids according to this consensus statement. It has also evidence grade C and level of certainty is low. Long-term opioid use is not recommended at all, and we must discourage. Other drugs also have been mentioned, like hydrocortisone and tryptophan, gosintropin, ostigmine, and gabapentin, but that shows no improvement. And abdominal binders or aromatherapy, that should be not recommended. And what procedural interventions may be used to treat? Interventional, we must consider, like if patient is undergone spinal anesthesia with a low gauge needle, we can recommend use of greater occipital nerve block, and it is helpful, and even sphenopalatine ganglion block. But as a routine measure for the relief of headache, it is not recommended as its evidence level of certainty is low. These great nerve blocks are novel therapies, and we need more studies and more evidence in order to recommend as a routine. And spinal and epidural morphine, that is also not recommended. And epidural saline, we see sometimes anesthesiologists use. It shows and it gives temporary benefit to the patient, but its evidence grade I and level of certainty is low. And use of dextran, gelatin, or hydroxyethyl starch, which is not recommended. And it also has level of low certainty. And now fibrin glue. Fibrin glue as a routine, it is not recommended. And it must be reserved for management of PDPH, which is refractory to first epidural blood patch. And then if there is a contraindication for autologous blood injection. Is imaging required in PDPH management? For this question, since it is a clinical diagnosis, imaging must be considered when we think of an alternative diagnosis, like brain imaging can be considered if there is non-orthostatic headache, and or if the headache develops after an initial orthostatic headache, or when headache after suspected dural puncture. Like if the headache onset is more than 5 days, then we should look for alternative diagnosis. And secondly, the presence of focal neurological deficit, visual changes, alteration in consciousness and seizures, especially in the postpartum period, and we must ask for routine imaging. What are the contraindications for epidural blood patch? Epidural blood patch is contraindicated when the risk of epidural hematoma was low, level of certainty is moderate, and low risk of epidural hematoma can be for those who are having low platelets. So before giving epidural blood patch, we must follow the regional anesthesia society's guidelines, then only consider. And the second contraindication, which is if the patient is having febrile condition, or like if there is any other systemic signs of infection. Its evidence grade C, level of certainty is moderate. When and how should an epidural blood pressure be performed? When there is refractory, PDPH is refractory to conservative therapy, and if it is impairing the activity of daily living, we should consider it has evidence grade B. We must offer to the patients. And also presence of severe neurological symptoms, example hearing loss and cranial neuropathies, level of certainty is moderate, so we must offer. And then epidural blood patch is performed within 48 hours of dural puncture. We must counsel the patient that there is very high chance that the patient will be needing another epidural blood patch. Its evidence is grade B and level of certainty is moderate. And also epidural blood patch should be performed ideally one space below the initial. And how it should be performed. Therapeutic epidural blood patch should be performed like for all procedures that we do in anesthesia, like spinal and epidural, or strict aseptic technique should be observed in this one, in both collection of the blood and also by introduction of blood. And decision to perform epidural blood patch under the radiologic guidance, it should be individualized on the basis of patient factors. Though its evidence grade I and level of certainty is low. And then transforaminal approach to the epidural space, which with radiological guidance, it can be considered for the patients who have prior undergone laminectomy near the site of dural puncture, or if the first epidural blood patch was unsuccessful. Evidence, however, does not support the routine use of blood cultures before an epidural blood patch. And how it should be performed. For all the procedures that we take, informed consent must be taken for an epidural blood patch, which should include the potential for repeat dural puncture and also backache and neurological complications. Its evidence grade A, level of certainty is high. And if the patient develops substantial backache or headache, example pressure paresthesia, injection of blood should be stopped and resumed based on clinical judgment when symptom resolves. It has level of certainty moderate, evidence grade B. And blood should be injected slowly and incrementally to minimize complications. And if the patient backache persists or increase in severity, or there is a change in nature after epidural blood patch, we must look for the other diagnosis. It has evidence grade C and level of certainty low. Epidural analgesia and anesthesia can be effective even in patients with a history of epidural blood patch, and we should not be withheld since patient had previous history. And what are the long-term complications? There are multiple complications which can happen. It's like chronic headache, backache, neckache. This will be most frequent. And patients can have depression, cranial nerve palsy, subdural hemorrhage, and also cerebral vascular sinus thrombosis. It has level of certainty moderate. But whether this epidural blood patch, can it prevent or treat this sequelae? It is unknown. It has low level of certainty. And how should patients be followed up? All this epidural blood, after epidural blood patch, patients should be followed until headache resolves. Even if we don't use the blood patch, we should follow the patient till the headache is resolved completely. And if the symptoms are worsened despite an epidural blood patch, or new focal neurological symptoms appears, or there is a change in nature of headache, we must consider urgent neuroimaging and referral to neurosurgeon. Thank you. This my presentation is over. Any questions?
Yeah, thank you, Dr. Kuma Abdul Razak. It was a wonderful presentation regarding the post-dural puncture headache. But to tell you very honestly, the incidence of post-dural puncture headache is not much, very, very insignificant when compared to those days when I was doing my post-graduation in 91, 94. Subsequently, because of the several factors that have come into vogue and the several evidences that we had come across, the incidence has substantially reduced. That's why I was really wondering what exactly you're going to say, but I must tell you that you have put a very good show regarding the evidence and diagnosis as well as the management part of it. But to tell you, something about this post-dural puncture headache. After the smaller gauge needles and then the non-cutting things, the incidence has very significantly come down. I remember of my days when we used to do the epidural blood patches, but those things are no more practiced as of now. But I must congratulate you. It was a very good presentation. And now my other chairperson, Rizana Ghafoor, if you have got anything.
Thank you. Thank you, Dr. Dosoma. That was a very comprehensive coverage of everything we have gone through. Yes, I would like to add to that. I think when there are trainees in units where there are trainees, and especially in obstetric units, there still might be incidents of post-dural puncture headache. And although the overall incidence is low, when it happens to a patient, for them, sometimes it can be very distressing. So I think it's important to have a sort of, as you mentioned, practice guideline or protocol to follow through so that everybody does the same things, going through the differential diagnosis, excluding simpler causes of headache, and then coming to the diagnosis of post-dural puncture headache, and then treating it accordingly. Yes, as you have said, I think the incidence overall has come down greatly from the previous times. Thank you, Dr. Soma.
Thank you, both chairpersons. I chose this topic as recently I have had a very patient who had a post-dural puncture headache after an unintentional dural puncture. And I have had this patient with me for more than 1 month. Repeatedly, she has been coming with complaints, and but the headache resolved even after like 1 month. I had no courage to do an epidural blood patch for this patient because I have not seen in my residency, and also during my practice anyway, I have not seen how to do that, and that was keeping me like a bit hesitant to give an epidural blood patch. And second reason that chose this topic was that most of the recommendations given here is a level of certainty is very low, and the reason they have shared is it's due to the less sample size and the less number of studies, and maybe we should be more like focusing on studies. More of the studies should be done, I think, in future, so that the level of certainty can be like high, and then they can recommend in recommendations to do like robustly, like to do like steps like should done this, like that. That's why I have chosen. Thank you.
Yes, to offer epidural blood patch for somebody who has developed a severe headache because of an epidural, it seems a bit contradictory, and to again explain to them that they have the same risks is a bit difficult. But I have seen that it does work when you give an epidural blood patch. There's a dramatic response usually with the headache. And I know in some countries, like the US, they do sphenopalatine ganglion blockade. They send the patients with local anesthetic. They discharge them and they ask them to soak a cotton bud with local anesthetic, and they teach them to insert it into their nostrils to block the sphenopalatine ganglion. I think they do it a couple of times in the hospital, teach them how to do it, and then they discharge them with that. And they are able to do it themselves. That seems like a more non-invasive method of treating, but I don't know how much it is practiced in other countries.
Ma'am, we have few questions in the chat box. Dr. Ibrahim Ibn Yamin Shirzad wants to know what is the best prevention for post-dural puncture headache, if there is any.
Dr. Soman, would you like to answer? Or I don't think there is a way of preventing it at all, even if somebody is very skillful. If for any reason the technique itself becomes difficult, for example, due to the anatomical structure, or if the patient is obese, if we have to try a few times, there is always a chance that you might inadvertently puncture the dura. And also it can happen even with a spinal, so I don't think there's a way of preventing it. But I think one important thing is to explain to them beforehand, before doing the procedure, that this is something which can happen, so that when it happens, it doesn't take them by surprise, and it doesn't become a very distressing situation for them.
Right, ma'am.
Sorry to jump in the conversation. I'm Dr. Khoja, one of the anesthetists here in UK. Up here, we come across usually these cases of headache. And well, we teach to our trainees nowadays that they should use saline for prevention rather than the air technique. And if you compare the saline and air in doing the epidurals, I think the chances of epidural and PDPH is less in the saline group. It's well documented. The other thing I was wondering about, I've written in the chat box as well, that like it comes a very confusing picture when the patients have already chronic headache off and on, and they start complaining of headaches and offering of the blood patch in these circumstances, because this is just a clinical dilemma. Whether this is migraine, whether this is chronic headache or just a postural headache, and the history is not very confirmative, then probably the offer of epidural blood patch can be counterproductive as well. Thank you.
All right, sir. Thank you very much.
Thank you.
We have more discussions. Dr. Ujma wants to say that back when they were using 25 gauge Quincy's needle, they did have PDPH, but she says that they had very good results with gabapentin. So, any of you would like to?
Yeah, Neha, I'm Dr. Kausar from Bangladesh.
Yes, sir.
Dr. Khoja has raised very important issue regarding the patient have previously headache, and not only headache, the headache and back pain combination. This is not very uncommon, and
Right,
the following the cesarean section, the back pain and the headache is aggravated at the same time, and it may confuse the diagnosis of the PDPH. In that case, I think the MRI of lumbosacral spine, it can be very helpful. You can see in the CSF, that is a watery shadow. There's a black shadow in the T1 image, and it's a white shadow in the T2 image of the MRI. So I think MRI is a very important radiological imaging to finally diagnose that it's really from the PDPH or from the other thing. So before doing any procedure, any confusing cases, so must do the evaluation. And thanks.
I think we lost connection.
Yeah, I guess. Yes, sir.
So there are a few more questions about effectiveness of gabapentin in patients with PDPH.
I have no experience with gabapentin. In this consensus statement, it's like it has low level of certainty. So maybe we should do more studies with gabapentin and effectiveness.
Ma'am, how to troubleshoot if the second blood patch also fails? This is a question from Dr. Raksha Kundal.
Dr. Rizada, maybe you could help.
Well, I have personally not come across a patient with 2 blood patches and still having severe headache. Although I have come across patients with 2 blood patches. I think people would be reluctant to do any more invasive blood patches, and I don't think it is recommended as well. A lot of reassurance, and after excluding other serious conditions, I'm sure after second blood patch, if it is still very severe, you would image them as well. I think reassurance and just simple analgesics would be the way to go. I don't know if somebody has any other
Yes, sir, ma'am.
recommendations.
This recommended this. So you
Hi,
can.
can I speak for a while? Yeah, I'm Dr. Basu
Yeah.
from Nepal, and I did my fellowship from Canada, Mount Sinai Hospital, where it was the major obstetric center. The complicated obstetric case used to be dealt over there, and they used to practice almost like 80 to 90% of liver epidural analgesia. So we had a lot of cases over there where patient had PDPH actually. Probably, I don't know, PDPH as mentioned in the chat box and experiences just now shared by all of you. PDPS, I think, is more common in the Western world than in our world. Probably they practice more liver analgesia. So over there, they were a little bit more aggressive with epidural blood patch. When the patient had severe form of PDPH, I mean, once they have the epidural puncture, the dural puncture after the epidural insertion, and patient develop the symptoms, they used to categorize as mild, moderate, severe. Once the patient who had severe symptoms, then they used to do early blood pass, and they used to repeat after 24 to 48 hours if the patient did not improve with the first epidural blood pass. And the result over there was promising. And I had one patient over here who required blood patch actually. She was not okay with the conservative management. However, she was okay. She got better with the epidural blood patch. That was the out of 2 to 3 experience, that was the only blood patch related with post-dural puncture headache. I mean, epidural analgesia headache. Other 2 experiences for me at my center were related with spontaneous intracranial hypotension because of the trauma, where there was CSF leakage from cervical level actually. So the symptoms are similar to that of PDPS. Those patients also got relieved because of the epidural blood pads.
Thank you very much.
Just to complete it, that you rightly said that it's more common in Western world, but because up here probably they follow the patients more tightly. I think that might be a reason. That the incidents in our part of the world, in Southeast Asia, people don't follow the headache or take it very lightly. That can be a reason. But the second thing about the repeat epidural blood patch, I have personally an experience on few incidences that with the second epidural blood patch, the success rate crosses more than 90%, as compared to the Guideline Society in 2021 and 2022. They say the first epidural blood patch only relieves up to 40% of the headache. So this is a definite entity, and we should take it seriously. And we cannot say that like it's a non-existent problem. It is a problem, but we have to follow it up tightly. Thank you.
Sir, I would like to tell about my case, which required second blood patch, and after that it was not relieved at all. And patient was so desperate, and she was having so much of the pain that she desperately told me, "Ma'am, please give it another try of blood patch if it really works." So, with her consent, I went for third because she was very desperate and in pain. And with third, it resolved. I did not find much literature like giving of third patch, but this was the one case where blood patch relieved her post-dural punctural headache.
Thank you, Dr. Raksha, for your experience. There are a few other questions in the chat box, Dr. Neha.
Yes, sir, there's another question from Dr. Prami. She says that it's difficult to counsel the patient for inserting another needle which is larger than the spinal needle itself for a blood patch. So how do we go about counseling the patient for the same?
I think that is what Dr. Jitana ma'am was mentioning. It is quite difficult to convince them. Correct, ma'am?
Yes, yes.
Yes.
And also again with the same risks. Sometimes it's really difficult to explain to them, but explaining to them the chance of relieving the headache, I think it's the way we explain which would be important to them, in a way that we reassure them. But at the same time, letting them know that there is again a risk with it as well. Regarding gabapentin, I don't think it's commonly used in the protocols in UK. It's the simple analgesics with caffeine which is used routinely along with epidural blood patch. Even sphenopalatine ganglion block is not used here. And somebody had mentioned neostigmine. I don't think it is used here either. Neostigmine. I don't know if anybody has had any experience with using neostigmine to relieve the headache.
Right, ma'am. Ma'am, the last question is, what will be the MRI findings in PDPH?
There will not be any MRI findings in PDPH. The main thing is to exclude a subdural hematoma or a cerebral venous thrombosis, which are the other main causes of intracranial pathology, which can cause a severe headache.
Right, thank you so much. Yes, sir.
One last question. I think Dr. Mrunalini from BJMP Ahmedabad wants to know how much blood is to be given through the epidural route for the blood patch.
So usually we take about 15 mils. Usually we take 20 mils and inject about 15 mils, and it is injected very slowly. Sometimes even with 10 mils, the patient feels relief and you don't have to actually give the whole thing. On an average, I think 15 mils is the usual amount used.
Correct. So I think that is all. Those are all the questions that we have.
Can I just add one more thing? I'm sorry.
Yeah, sure.
I think like there are recommendations related with epidural and spinal, intrathecal morphine, where the incidence has gone much with the use of intrathecal morphine. Do you agree with that? Like the floor?
Sorry, I didn't get you. Intrathecal.
Yes, use of intrathecal morphine, or like if you give epidural morphine as well, the incidence related with PDPH after the dural tap is much less actually. So whenever you have dural puncture, you practice like applying for the liver analgesia. In that case, if you just give intrathecal morphine or epidural morphine, like intrathecal morphine, definitely, that will also reduce the incidence of PDPS. There are lots of literature actually, and even ERAS after cesarean section has also recommended that.
Yeah, intrathecal morphine is routinely being used here for the spine after spinal anesthesia for the cesarean sections here. But what I'm saying is that like it can mask your headache, whereas this is an actual pathological problem going on, like the low pressure headache. So if you're masking the headache by giving morphine, epidural morphine, I mean, it can just mask, and then God forbid, patient can end up in some complications like cranial nerve palsy or subdural hematoma or something like that after a week or so. So that's not a very good idea to mask the symptoms when actually the pathology is there.
So those are all the questions that we have. Bhimeshwar sir, the chairpersons, Dr. Rizana, ma'am.
Yeah, thank you. Thank you, Dr. Nishant, and everyone who has participated. I see someone raising his hand.
Yeah, he can unmute himself. Dr. Mirza, Dr. Mirza Mohammed, you can please unmute yourself. If there is anything you wish to state or comment, you can just unmute yourself and express yourself. Dr. Mirza. I think he is having some problem unmuting himself, maybe.
Okay, if there's nothing, then on behalf of my co-chairperson, Dr. Rizana Ghafoor, I hand over to you, Dr. Nishant. Madam, you have anything to say?
No, thank you so much. It was a very good discussion.
Yeah, thank you, madam. Hand over to Dr. Nishant and Neha.
Thank you, sir. I think indeed it was a very extensive and a wonderful discussion on both the topics. We had emergency airway in trauma patients and PDPH, most essential topics for anesthesia. I'd like to thank all the chairpersons and speakers for this amazing and indelible and a very enthralling session. Thank you, sir. Thank you.
Thank you.
Thank you, sir. So,
Thank you, everybody. It was a great occasion. Thank you very much.
Yeah, I think we have the vote of thanks.
Yes, sir. I would now like to invite Dr. Virender Sharma, sir, Treasurer SAARC AA, to have a word from him for the vote of thanks.
Viren, unmute yourself.
Oh, I'm sorry. Thank you, Neha. Good evening, all. First of all, I would like to thank the two senior-most members who have been associated with the formation of SAARC initially, Professor Madam Devekar and Professor Saida ma'am. Your presence is really motivating for us that the SAARC continuous programs in education and they continue. So on behalf of the SAARC officials, I thank you both. Then I would like to thank the speakers. The best thing I liked today was the interaction. I mean, the speakers, they presented well, but the number of questions and the explanations given and the interactions happened. Last time when I gave the vote of thanks, I wished that next time I would see more members from different societies. And today I can see not only from Pakistan, Maldives, the senior persons from Bangladesh society, they are as well present. So I'm hopeful that in future we'll come to know about each other. At least we'll be able to see each other virtually and know each other, what their thought processes are. So this is a very good initiative taken by our secretary, president, and other executives, that it's not possible for us to meet physically. We all know that. But these programs, I'm sure by the time we'll have the SAARC conference in Bangladesh, I think many would be motivated to attend, knowing well that, yes, now I'm going to a place where I know many. So that's a positive aspect of it. Thank you to the chairpersons, Professor Saida ma'am, Dr. Naveen, Dr. Rijana, Dr. Bhimeshwar sir, both the speakers, Dr. Farjad, Dr. Dusuma, all the senior officials of different societies of SAARC AA, my seniors from ISA, Dr. Bhimeshwar sir, academic chairman, Dr. Venkatgiri, president of SAARC, Dr. Naveen, my colleague, secretary of SAARC, and all those who have attended. No doubt today's attendance was really impressive, and I'm hopeful in the next webinar, we'll see more and more participants from different countries. So thank you so much for attending. Hope to see you soon. Thank you.
Thank you.
Thank you very much.
Thank you, and see you all for the next SAARC CPDP program on the last Friday of June 28th with presentations from Bhutan and Afghanistan. Thank you very much. Have a nice weekend. Good night.
Good night.
sir.
Thank you all.
Good night.
Thank you.
Thank you. Yeah.
Good night, sir.
Thank
Good night, everyone.